Well, thankfully, I have several consulting agreements. None will have any bearing on my thoughts on carpal instability. Over the next 20 minutes, I'll try to shed some light on what's old, what's new, and what remains a total mystery to those of us in this arena. So let's start by defining wrist instability, as Sanj Kakar and I have worded it in Green's new edition due out next year. A symptomatic condition involving abnormal carpal motion during loading activities of the wrist. And to pique your interest with an actual 2018 OITE question. This 27-year-old female presents with these radiographs 8 weeks following open reduction of a non-displaced scaphoid fracture. You suspect what type of instability? And the answers are as you see them. So by the end of this talk, I hope that you can answer this, and let's hop right in. Understanding the three bones of the proximal carpal row and their ligament connections is vital to the understanding of carpal pathology. These three are the only truly mobile bones of the carpus, as the distal carpal row is rigidly fixed to the hand. These bones are inherently unstable, guided by the articulations proximally and distally, and restrained by their ligamentous attachments. Over the past 100 years, two main theories of carpal bone kinematics have evolved to describe the wrist as organized into proximal and distal carpal rows, or alternatively as three linear columns. Both of these theories arose predominantly from two-dimensional radiographic studies of planar motion, that is, flexion extension and radial ulnar deviation. But because of the complex three-dimensional motion of the carpus and the coupled or dart-throwing motions required for most activities, many investigators have concluded that both theories are too simplistic to adequately describe carpal kinematics during wrist function, and that functional wrist kinematics requires a combination of both. So what is this thing we call the intercalated segment? Landsmeer's eloquent 1961 paper furthered the idea of inherently unstable link by describing the intercalated bone as one whose motions are entirely governed by its neighboring segments, like the segments of the wooden snake he used to play with. His work was illustrated by the stacked phalanges of our digits and can equally well be visualized in the central column of the wrist. Landsmeer and Dobbins expanded his concept of the intercalated bone in this 1972 landmark article by including the neighboring triquetrum as an intercalated segment, at once rigidly connected but inherently unstable. This concept furthered what is widely now accepted as the carpal row theory of kinematics, proposed by Desto nearly a half-century earlier. There are no tendon insertions on the intercalated segment, thus its motion is entirely dependent on mechanical signals from the distal row. As the hand unit moves, it follows passively. All bones of the proximal carpal row move together, albeit to different degrees, and limited by a set of surrounding ligaments. The scaphoid coordinates its motions through the tight interosseous ligament. Critical to an understanding of the kinematics of the carpus is an understanding of the ligaments of the proximal carpal row, as all instability patterns are manifested as abnormalities of proximal carpal row motion. As Dick Berger demonstrated 20 years ago, the scaphoid and the lunate are the key players of the proximal row and are tightly linked by a complex scapholunate interosseous ligament made up of three component parts, of which the dorsal is the most critical. The ligament's vulnerable to an injury with a fall on the outstretched wrist, which can tear all or part of this important structure. It can be thought of as the ACL of the wrist. The so-called secondary volar stabilizing ligaments of the scaphoid and the proximal carpal row include the radioscaphocapitate, the long and the short radiolunate ligaments, and the STT ligament complex. The tight envelope of the scaphoid's ligament supporting system is demonstrated here. The dorsal ligaments are equally important counterbalances to the volar complex, and these include the important dorsal radiocarpal ligament, the dorsal intercarpal ligament, and Steve Vigas emphasized the clever oblique orientation of these ligaments, which, like an accordion, expand and contract with rotations of the wrist. In addition, Berger and Doyle described the dorsal scaphotriquetral ligament, the exact location or function of which has never been adequately clarified. In this drawing, the DST is incorrectly portrayed proximal to the DIC. We feel it's a critically important structure that has largely been overlooked. We refer to these three ligaments collectively as the dorsal ligamentous complex. This shotgun exposure of the human wrist demonstrates these relationships and the unique labral-like arch that the dorsal scaphotriquetral ligament creates for the nearly acetabular receptacle of the midcarpal joint. In this inset view of the dorsal wrist axially, the DIC can be lifted to demonstrate the deeper and very stout dorsal scaphotriquetral ligament inserting on the distal waist of the scaphoid. We're currently characterizing the anatomic and histologic attributes of this seemingly important ligament. So let's seg into a instability classification. Weber's work was instrumental in understanding how the mechanical signals from the distal row regulate the motion of the proximal row. With all ligaments intact, the lunate is delicately balanced by competing flexion and extension forces on either side. In our first fully segmented video of the live human wrist, which we made in 1998, we can see that the injured proximal carpal row moves as a unit in both flexion extension and radial ulnar deviation, guided by the scaphoid. Guilford had recognized back in the 40s that detached from the scaphoid, the central column was stable only in traction. The scaphoid link is thus critical to prevent its collapse under load. Fisk later illustrated that concept with the effect of waist fractures of the scaphoid and their disruptive effect on the proximal row and the central column. Intact, the proximal carpal row and the central column of the wrist are in kinematic balance. With disruption of the scapholunate ligament or scaphoid waist, the scaphoid is separated from the proximal row, initiating a slide into the first major class, dissociative carpal instability, and the inexorable slide into rotational instability, postural changes of the scaphoid, postural changes of the intercalated segment or DISI, and ultimately degeneration and slack arthritis. Is this a sequential progression? Actually, we've had no natural history studies to define that. Unlike slack wrist, ligament attenuation or rupture is not necessary for the development of the humpback scaphoid and DISI of snack wrist. As Watson described this 30 years ago, this is a predictable and relentless pattern of degenerative arthritis, generally sparing the radiolunate joint. The best defense against snack is to prevent it by early surgery on a scaphoid non-union. A similar situation can occur with traumatic disruptions on the ulnar side of the wrist. With disruption of the lunar troquetral ligament and some of its surrounding critical ligaments, the scaphoid and the lunate tip into flexion, also called VISI. Thus, we have two major classes of carpal instability as defined by the site of ligament injury, either within the rows or between the rows. Non-dissociative instabilities are more difficult to understand and reproduce, and we'll go there now. Non-dissociative instability is called carpal instability non-dissociative or SIND, and it's a general class of carpal instability without a break in the proximal or the distal row, involving ligaments spanning both the radiocarpal and the midcarpal joints, and it also might be called proximal carpal row instability. It has multiple etiologies. A working definition might be abnormal force transmission or kinetics across the proximal carpal row, but manifested by abnormal static or dynamic motion, also called kinematics, of the proximal row. You can see in this fluoroscopy how the whole proximal row tips up and down depending on forces on the hand and with radial ulnar deviation of the wrist. You can see that in this clinical view also of a so-called midcarpal shift test, demonstrating the proximal carpal row shifting up and down. We classified these into four major classes. The two on the left, on your left, are the most common, SIN-VISI and SIN-DISI, which are generally manifested by patients with lax ligaments. We have a combined class which shows hallmarks of both, and then an adaptive class based on generally on malunions of the radius, which throw the proximal carpal row into an adaptive posture. But late this year, we added a fifth class called traumatic SIN, based largely on a new paper by Folk and Fernandez in the Journal of Hand Surgery 2020 of non-dissociative instability associated with distal radius fractures. Together with my colleagues in Australia, Mark Ross and Greg Cousins, we've also identified this in patients with confirmed scapholunate and lunotriquetral ligaments intact and a series of 9 patients with non-displaced scaphoid fractures. MRI and arthroscopy confirmed the identity of the ruptured extrinsic ligaments that enabled the lunate postural changes. Like boats in a harbor, which need bow and stern mooring lines, the lunate has flexible dorsal and palmar tethers that stabilize it through an incredible range of motion and applied loads. Disruption of one or both of the volar dorsal combinations at the midcarpal and the radiocarpal joints allow the lunate to tip into a reciprocal fashion. Disruption of the opposite combination allows it to tip into VISI. This is the nature of SIN DISI and SIN VISI. Moving on to the third class of carpal instability complex. We see it in three flavors: transverse, which is either ulnar translation or palmar translation. There is, in fact, a dorsal translation as well, but I've not seen a radial. Combined, which is our perilunate fracture dislocations, and then longitudinal disruptions of the carpus, even more rare, sort of like a Lisfrank's fracture of the foot and ankle, down the columns of the wrist and dissociating metacarpals from one another, and including usually very severe injuries to vessels and nerves. So when faced with radiographs like this, there's almost a dizzying array, pardon the pun, of repairs available to treat scapholunate ligament injury. What's important to understand is that despite dozens of creative surgical techniques, there's frustratingly little evidence that we've moved our overall success rate forward. No single repair that provides uniform success, and no consensus amongst the leaders in the field as to guidelines that are available to help us choose amongst these repairs. So what initiates degenerative change, and how can we prevent it? Is it rotary subluxation of the scaphoid? Is it gap? Or is it DISI? Well, right you are, it's scaphoid dorsal translation. In two recent studies, we demonstrated statistical associations between scapholunate ligament rupture and translation of the scaphoid onto the dorsal rim of the radius. With that, the midcarpal joint is disrupted, breaking the acetabular container of the capitate and allowing it to drift dorsally. Its dorsal moment accentuates the tendency of the detached intercalated segment to tilt dorsally, and the scaphoid's dorsal rim position leads to rapid cartilage loss. We thus question Watson's nested spoon analogy and propose instead that symptomatic patients have more than rotational instability of the scaphoid, but also scaphoid translational instability. Dorsal scaphoid translation is easily detected on true lateral radiographs in relationship to a line through the dorsal rim of the scaphoid facet. The articular surface of the distal row is at once elliptical in the coronal plane and spherical in the sagittal plane because of its obliquity to the acetabular receptacle of the proximal row. This magnificently illustrated video by Isao Moritomo's schematic of the oblique axis of the midcarpal joint shows it as a spherical unit in this oblique plane. Unlike the orthogonal and arbitrary planes of flexion, extension, radial deviation that we use in radiographs, the midcarpal joint enables the coupled motions of radial extension to ulnar flexion, or the so-called dart thrower's plane of motion. In 2005, we demonstrated that the proximal row is nearly still during this important arc of motion. Work at our institution and many others across the globe demonstrated that nearly all complex motions of household, occupational, and recreational activities occur predominantly through the midcarpal joint. And through collaborative work with anthropologist Mary Marsky and colleagues at Arizona State, we proposed that the dart thrower's motion was actually unique to humans and may have conferred a survival advantage to early hominids during the transition from tree-dwelling vegetarians to bipedal carnivores, allowing them to hunt and to protect their young. Further anatomic study on cadaveric wrist demonstrated the physiologic axis of the wrist lies not in the anatomic planes of flexion extension, but rather in an oblique plane from radial extension to ulnar flexion. So our primary goal of scapholunate ligament repair and reconstruction is to restore midcarpal architecture and function. And that is evidenced by containment of the midcarpal joints, by reuniting the proximal carpal row, and most importantly, eliminating dorsal translation. Yet, we continue to struggle with the outcomes of scapholunate ligament repair and reconstruction. In this study out of Minnesota by Julie Adams and colleagues, 82 wrists were studied, showing a 20% failure rate as early as 6 months with primary repair, and somewhat better results with ligament reconstructions. So how can we improve the treatment of scapholunate instability after all these years? I think we need to understand its etiology better. First, there's a primary loss of the joint couple, and that's the scapholunate ligament. We understand that. But secondary, it's a rupture or attenuation of secondary restraints, which I don't think we completely understand. So which ones? Are we talking about the STT ligaments? Are we talking about the volar capsular ligaments? Or are we talking about the dorsal ligamentous complex? Or a combination of all three? A recent cadaveric study by our group demonstrated that scapholunate injuries alone do not cause DISI. That division of the long radial lunate, the STT, or the DIC lunate attachments cause statistical increases in radial lunate angle, but the DISI was only noted when the STT or the complete DIC were divided in addition to the scapholunate ligament. We now refer to the STT, the long radial lunate, and the DIC as critical stabilizers of the carpus. I don't have sufficient time to elaborate on the effects of different ligament sections on gap, angle, and translation, but what seems to be evident is that various postural abnormalities of the carpus may be dependent on injury to different secondary stabilizers or critical stabilizers. As we continue our search for the ideal scapholunate repair, we should consider gaining a detailed inventory of injury to additional critical stabilizers using either MRI or arthroscopy and customizing our repairs accordingly. With so many creative repairs from several different classes, we might consider an individualized approach rather than a traditional one-size-fits-all approach to dissociative carpal instability. So have we been barking up the wrong tree? Have we been concentrating on the wrong parameter of scapholunate dissociation? It's more than a gap. From Adelaide, Australia, Michael Sandow's novel reconstructive technique addresses not only the scapholunate gap, but reconstructs each of the critical ligaments of the carpus. The technique uses a 3 mm flexocarpi radialis tendon graft based distally and reinforces it with a 2 mm synthetic tape. Each is passed and anchored to avoid stress relaxation in each of the bones. I've now switched entirely to this technique for all of my most difficult reconstruction and have a successful cohort of 20 cases that I'm following prospectively. Our video of the technique is available on ViewMedi, HSS, the ASSH library, and YouTube under Anafab. So it may be time to retool our diagnosis and treatment of scapholunate instability. Diagnosis should include an inventory of all injured structures using arthroscopy or MRI in high resolution, followed by staging and targeted treatment of the particular injured ligaments. So it's now time to test your recall. This 27-year-old female presents with these radiographs. What type of instability is it? Correct. Non-dissociative VISI. So thank you for your attention. And I'd also like to thank the literally dozens of my colleagues at HSS, but also around the globe who've contributed to helping me improve my understanding of this fascinating topic. Thank you very much. And so I'm going to stop my share and introduce our president and leader of this course, someone who's got 700 people watching this around the globe, Dan Pollich. Take it away, Dan.